So Dr. Ennis online, and this evening we do not have the permanent secretary. He's out unavoidably. All right, so today we're going to go into the regular updates. Just by way of context, Jamaica continues to see an increase in the number of cases, COVID-19 infections in the population. And of course, because of the sheer numbers, we are seeing an increase in hospitalization. In the last 24 hours, we have confirmed 860 new cases, bringing our total cases on record to 116,944. And regrettably, we have also recorded 6 deaths, 3 of which were previously under investigation, so not over the past 24 hours. The total deaths from COVID-19 now stands, unfortunately, at 2,561, with 360 still under investigation and another 210 noted as coincidental COVID-19 deaths. Our positivity rate remains high. Certainly well above what we would like. Last 24 hours, it numbered 47%. In context, of course, the sort of benchmark where you're comfortable is 5 or below. It's at 47, and the 7-day average is 48.9%. So yesterday's positivity rate has come down somewhat from the overall average. The average is higher, 48.9%. Still way too high to be comfortable. And we certainly encourage Jamaicans to take note, and in taking note, to take the necessary precaution. I now invite the Chief Medical Officer to give the regular update on the numbers and other related data around the COVID-19 response.
Good evening, Minister. Good evening, everyone. So this is our update. The data is as of the 19th of January, and just to repeat some of what the Minister said. So yesterday we confirmed 860 new cases, which brings our new numbers up to 116,994 cases. We also recorded 6 new deaths, and that brings our numbers to 2,561 deaths. So our daily positivity rate is high at 47%, with the 7-day average at 48.9%, and our case fatality rate is at 2.2%. With respect to the type of cases that we're seeing in terms of the age groups, we're still seeing our highest numbers within the 20 to 29 age group and the 30 to 39 age group. So it is still the young adults that we're having the greatest amount of exposure, and these persons are coming down with COVID. Next slide. Our case fatality is still highest in the older population, with a 19.8% case fatality in the over 90s, a 14.6 case fatality rate in the 80 to 89, and 70 to 79, 9.5% case fatality rate. And this is in comparison to the younger age groups, the less than 10, 10 to 19, and 20 to 29 age groups, where we're seeing a 0.1% case fatality rate. Across the island, over the last 2 weeks, we have 14,478 cases that were confirmed. So these are considered active cases that we presently have in country. These cases are distributed right across the island, and the community map that you are seeing on the screen will show that how densely we are seeing the number of cases in St. Catherine and Kingston and St. Andrew. But right across the island, we have 76.5% of our communities, a very high level of geographic spread. 599 communities out of 783 communities have confirmed cases. in terms of the numbers, the absolute numbers of cases being confirmed each day, on the screen what we will see in blue, the number of cases, and we can see that clearly that we are in our fourth surge and that we are still climbing up, even though where we are now is several times greater than the peak of the third surge. We are still on an upward climb. And this also in terms of the admissions that we are seeing in pink, the number of admissions are climbing over the last couple of weeks, going up quite steeply. When we look at the numbers in the parishes across the island, the 14 parishes, we see that the picture is the same. The numbers are climbing. This fourth surge is much higher than the third surge, and the numbers are going up, not going down at all as yet. In terms of the number of deaths, over the last couple of weeks, we would have seen the continuous decline in the number of cases, and for some days we were recording 1 or 0 deaths. Now, over the last 2 weeks, we are seeing a climb in the number of deaths. And even though the Omicron variant is said to be a milder virus, it still causes some severe illness. And even though it is a smaller percentage of persons that overall will have a severe illness, because of the large number of cases that we are seeing, the absolute numbers of severe illness is going to be high and will result in deaths. And also remember that in Jamaica, we probably do still have a Delta variant that is circulating, and so that also can lead to severe illness and deaths. So in terms of the 7-day summary for hospitals, we would have started the 7 days on the 14th of January with 686 cases, and these are both suspected and confirmed cases in hospitals. And we would have seen that over the 7-day period, which would have risen, and we're now at 828 cases that are occupying COVID-designated beds. And you would recognize that this is over the 700 beds that we would have had designated for COVID. So we can see here in the blue line is showing that the increase in the number of beds being occupied. And you can see that we are at 100% bed occupancy for COVID beds. And this would be, it would be still less than where we were at the same time in the last peak, we would have gone up to over 150, almost 180% bed occupancy. And we can see that we are climbing still, and we're not yet at the peak. We're at 100% bed occupancy already. And this gives you the daily, when you look at the daily numbers, you would see that over the last couple of days, we would have gone beyond that 100%. So the weekly average that was seen on the previous slide would say that we're at about 100%. But when you actually look at it day to day, you would see that we have gone way over the 100% on some days. And this puts us in an extremely high level of pressure on the hospitals, as we can see that we are in the red, the dark red zone in terms of hospitalizations. And across the regions, here we're looking at what's happening in each of the regions. And you can see that in 3 regions, the southern region, the northeast region, and the southeast region, we are in the red alert zone in terms of isolation beds for COVID. And in the western region, we are in the amber alert zone. So all our hospitals now are being challenged for bed spaces for COVID patients. Many of them are over 100% occupancy. This means that they are now, patients with COVID are now occupying other beds. And so this is why the ministry would have gone into emergencies only, because we were being affected by both the staff shortages, but now we're also utilizing other beds that we would have used for general admissions for COVID. In terms of the types of cases that we're seeing in hospital, you would have seen that over the last 2 weeks, the number of seriously ill persons are increasing. And in terms of seriously ill, we have the moderately ill, the severely ill, and the critically ill persons. Next slide. And here we can see that most of the increase that we're seeing are in the moderately ill group. However, over the last couple of days, we would have seen that the critically ill persons are increasing, and we're seeing a very sharp uptick in the number of severely ill persons. Now, the severely ill persons and the critically ill persons, these are the persons that are going to demand more oxygen. And as these numbers increase, then we are going to have not just a challenge with bed occupancy, but also a challenge with oxygen supplies. Fortunately, this slide is showing that the number of persons that are on mechanical ventilation have not started to go up significantly over the last couple of weeks. Yes, we are seeing a slight increase, but not significantly so. Next slide. But we can see here that the number of persons on high-flow nasal oxygen, and these are persons that are demanding up to 60 liters of oxygen. When you go into hospital and somebody put on a face mask on you or a nasal cannula, you're usually getting maybe about 5 to 10 liters of oxygen. When persons go on high-flow nasal oxygen, they're demanding up to 60 liters of oxygen per minute. And we can see that the number of patients that are falling into this category have been increasing significantly over the last couple of days. And here is where you're seeing this spike at the end of the graph is showing the number of persons admitted that are critically ill. And again, we saw that where that was down for a long period of time. And then over the last 2 or 3 days, we have now seen a spike in the number of critically ill persons. And this is where the demand for the high-flow nasal oxygen is coming in. And hopefully we will not see a lot of persons going on mechanical ventilation. But once you see this spike starting to happen, then it suggests that we may see that. What we're also seeing at this time is that the number of persons that are hospitalized in pregnancy are also increasing. And these are persons in late pregnancy or right around the delivery period, some of them in the postpartum after they have delivered period. We're seeing an increase in the number of patients with COVID at this time in this group. And this is not good because what we have seen is that persons at this particular time in pregnancy, they tend to develop severe COVID. And we are also seeing something new in terms of the increase in the number of children. Proportionately, we are not seeing more children than the other age groups, but because the numbers, the absolute numbers are increasing, then we are certainly being challenged on our pediatric wards right across the island. We're seeing the reports that the pediatric wards are now seeing an increase in the number of cases of COVID in children. So before I speak about the positivity rate, which is on the screen, I just want to point out that, you know, this feeling that because Omicron is a mild illness, that we can pretty much let it run loose. You can see that even though the majority of persons will have a mild illness, just because of the numbers, because of the high rate of transmission of this virus, the large numbers mean that even if only a small percentage of them get severely ill, it means that we're still seeing large numbers. And we're certainly seeing that reflected in the number of cases going up and the number of seriously ill persons going up in hospital. And then also a reminder to the public again that we know that with Delta we can get severe illness, and we probably do have both Delta and Omicron circulating at this time. In terms of vaccination status, we have been monitoring the number of persons that are coming into hospital with COVID, whether they are vaccinated or not. And what we're seeing is that the majority of persons, and yesterday's numbers when we looked at it, 95% of the persons that were on beds that we had their vaccination status, 95% of them were unvaccinated. And this has been the trend that we have seen over time. Between 95 to 98% of persons that are being admitted for COVID are unvaccinated. And this certainly means that persons need to get vaccinated because the vaccination will prevent severe illness and decrease hospitalizations and will have a decrease in the number of persons with poor outcomes. So, and this shows up on this slide where we'll look at the deaths that we've had since the 1st of March 2021. And up to now, we've had 2,024 deaths, a large number of deaths we've seen over this period. But 98.5% of these persons are unvaccinated. And we do have very, very few persons that have been vaccinated. And it does show that, you can get some breakthrough COVID cases. And these cases, when we look at them, are persons with severe illness, many of them with several comorbidities. And again, it points to the management of persons with their non-communicable diseases, how important it is that they get these under control so that they won't be in that severe group if it is that they get COVID. In terms of the vaccination program, we now have 22% or 604,365 persons that are fully vaccinated. And we have 5% that would have received one of a 2-dose series. So still only 27% of our population that has been exposed to vaccination. This is a very, very low rate of vaccination, especially at this time. 73% of the population unvaccinated. And this puts Jamaica at a continuous risk. Next. And here we look at the age groups with vaccination. Highest groups, 60 to 69 and 70 to 79. But we're not seeing these numbers move as we would want them to go up. The vulnerable age groups, we see that the highest rates of death in the 60 to 69, the 70 to 79, and the over 80s. And we're not seeing the vaccination level go up in these groups. They have been stagnant for quite a while, and we really need to protect these persons by getting them vaccinated. So overall, a very high level of geographical spread with over 75% of communities affected, a very high level of bed occupancy with extremely high pressure on the hospital situation in the country, high 7-day positivity rate of over 48%, very high transmission level, a reproductive rate of 1.9 when we look at confirmed cases, 1.9, 1.2 when we look at admissions, and we see once it is over 1, we're going to start having a lot of exposures. So we really do need to get these numbers down so that we can return the positivity rate down to below 5%. And a very low level of vaccination that is not really having any effect on, or much effect on the transmission in country. That's the end of the minister.
Thank you very much, CMO. So there you have it, folks. The picture remains concerning and very concerning. The key indicators, which was the last slide, the geographic spread, 76% of communities with COVID present. The positivity rate, 7-day average, 49, almost 50%. Very, very high, 10 times what is acceptable. The reproductive rate also very high. And the occupancy, bed occupancy at high alert, if you will, extremely high. And our vaccination level just inching up but much too slow. So it is a very important message to the country that we must take the necessary precaution. On Monday, January 17th, the ministry announced, as a result of these numbers and the impact on our hospitalization, that public hospitals would be dealing with emergency cases only. The public was asked and is still being asked to utilize discretion in accessing public health facilities. Outpatient clinics and elective procedures have been scaled down based on the level of staff and bed occupancy. And this continues to be the position, policy position down through the ministry to the particular institutions as we continue to experience these high numbers, and also, very importantly and concerning to us, the staff coverage being reduced or impacted by illness among our healthcare workers. On that note, I want to take this opportunity to just wish for those healthcare workers who have been impacted a speedy recovery. We met today with the medical doctors associations, the JMA and the JMDA, MAJ, and the JMDA, and also earlier this week with the Nurses Association of Jamaica to get their own perspectives as representatives of their membership on what was happening. And it's quite clear that the pressure is on and it is having an impact. I want to just thank them for their leadership, for their patience, for the fact that they are not, they are not panicking. They're trying to manage, and that is very important in these times. So I want to just assure the country that our healthcare workers are resilient and they are holding the front line, doing what they need to do, even at the risks that they are encountering. And I want to just commend the leadership of the Nurses Association and the Doctors Association for their contribution to the leadership that is required in this regard. Of the 16,830 healthcare workers, 669 were out due to COVID, which is a 4% or so. Now, on the face of it, it doesn't seem much, but if you dissect it around the type of worker, the nurses who are on the front line, the doctors who are on the front line, then those averages go up. So where it really matters, or matters most in terms of the interaction and the ongoing management of the process, is where we have the greatest impact, and that continues to be the case. So in that regard, we continue to encourage our healthcare workers, even while we recognize and are sympathetic to what has happened to them or is happening in terms of infections, to protect themselves. And we do provide all the necessary PPEs, etc. for that. But also as it relates to vaccination, I don't think we can emphasize that more, that the vaccination levels among our healthcare workers we would like to see increase from where it is, and as a result of that, giving them the protection that they deserve. For the week of January 14th up to today, January 20, our daily hospitalization went from 686 to 828, as was said by the CMO. This is now from the patient's perspective, and that is a concern. Currently, 14 hospitals are in the red alert zone of its COVID-19 isolation capacity. Of this number, 9 hospitals, Savannah Lamar, Port Maria, St. Anne's Bay, Mandeville Regional, Maypen, Lionel Town, University Hospital, and Spanish Town hospitals have surpassed their 100% capacity. All that means is that we have excess demands and have had to make provisions, sometimes in unusual places, corner off a section of A&E in a particular passageway, remove some of the other non-COVID patients or wards and transfer to COVID areas. in order to accommodate the more than 100%. So it places a lot of stress on the system. The remainder are over 85% capacity housing COVID patients. So some 14 hospitals are over the 100%, the remainder are 85%. As it relates to general capacity, 5 hospitals are in the red alert zone, which means these facilities have excess of 84% of their general capacity, and 6 are in the amber alert, 74% of capacity. So essentially we are moving out of the non-COVID areas to facilitate COVID. In terms of vaccinations, you would have heard the CMO speak to the fact that the numbers up to Wednesday, and this is a very important point, that slide, I don't know if you can get it back up on the screen, but I think it's so important. Around 117 patients in hospitals were moderately ill, and with 112 of those unvaccinated. 61 patients were severely ill, and of that number, 58 were unvaccinated. And of the 20 critically ill patients, 17 were unvaccinated. And I'm saying this to Stephen, our communication. We need to do a full page ad with that kind of information. And I think we need to have a to push that out there, because I think people need to understand that the reason why we have these numbers that are placing us over the 100%, and unfortunately, the reason why we have these deaths, and that's right, the death chart. That's the one. I want us to look at this and really pay a little attention to it, because it is so significant in what it is saying. It is saying that the deaths that we have had that are COVID related, 98.5 for all intents and purposes, 99%. That's 99 out of 100. That's 999 out of every 1,000 are persons who were unvaccinated. They decided, for whatever reason, that they were not going to be vaccinated. We have tried to explain why they should be. We have had one-on-one interactions. We have had these press briefings. We have had articles and advertisements. We have had community outreach. I've been to almost every community where there's an outbreak, speaking to people, the healthcare workers on the ground, the 1,500 temporary workers. And we have sought to overcome every objection raised. Impotence, fertility, chipping the vaccine, all the things that have been raised as concerns, whether it was too soon to discover whether this vaccine is healthy or not. We have offered the brands that people prefer, but nevertheless, so many persons have chosen not to get vaccinated, and we have vaccines in stock. Well, this is the evidence for you. COVID-19 and the worst impact, not necessarily whether or not you get the virus, because we're all susceptible to the virus, but what happens after you get the virus. Hospitalization and the most extreme death is largely, overwhelmingly, almost exclusively linked to persons who are unvaccinated. And I don't know if this chart and if this message can be any clearer. You run a significantly higher risk of dying from COVID-19, particularly if you have other complications, if you do not have your vaccine. 98.5%, 1,993 of 2024 deaths related to COVID-19 are unvaccinated. 0.7% partially vaccinated. That's 14 of 2024. 14. That means they have had one dose of a 2-dose series. And the 0.8% were fully vaccinated. That's 17 of 2024. Again, very, very clear. Now, I have not dissected why that 0.8% or 17 have died or have had a COVID-related death. Maybe they had significant complications, more than likely, and those complications were too significant for the immunity or immune status that they had to overcome the COVID virus. But the facts are the facts. The majority of persons who have passed are linked also to having an unvaccinated status. And I think that's so important. So I want to remind the public that even in this fourth wave, you do have an opportunity to get vaccinated. Some 250 access points, 7 days a week to receive any of the 4 available vaccines that we have so that you can protect yourself even if you are exposed to the virus. On the testing infrastructure, I'm happy to report that today I toured the University Hospital of the West Indies microbiology lab, and I think it's up there on the screen, where finally the first batch of samples to test for the variant strain started, having had 4 of a 7-day training, the genome sequencing machine. 6 healthcare personnel have now completed day 4 of the 7-day training by 2 international trainers from Illumina, manufacturers of the machine, and that is going well. I spoke to the team, and they are really applying themselves to the training process today, looked at the instrument, learned a little bit about the process, and very happy to note that we are finally commissioning the use of the machine. Remember now, we had gotten the machine some time ago, but had to wait on the manufacturers to send the trainers. We do and hope to get another machine sometime in the near future, but for now, this machine will provide, I think, our own training and therefore a speedier response to how much of this strain is actually in the population. So I want to thank the Public Health Lab and the National Influenza Center and the University Microbiology Lab, the team that have been a part of this process of providing this instrument, and the team that are now involved in the training process. So I am told that the batch that is now being processed, as seen on the screen there, are likely to be available sometime tomorrow. So 36 hours or 24 hours. It takes a while. So as soon as that batch comes off the system, we'll provide information to the public. And of course, we'll load up again to continue to do testing to give an indication of what is happening. We still have samples outside of Jamaica, and we'll await the arrival of those samples or the results of the testing around those samples. I want to do a final comment on an issue that has been raised around what our position is in terms of the response to COVID-19. I think there's an impression given that somehow with the fourth wave we have not been taking or have taken steps to manage the process to ensure that there are some restrictions and to balance the lives and the livelihoods that we speak a lot of, the government, the Honorable Prime Minister, myself, and others. And I just want to raise with those who are listening that we continue to have the protocols that have been established to minimize the spread of COVID-19 and continue to encourage Jamaicans, all of us, to abide by those protocols. You know, we have established the Disaster Risk Management Act, and I've had several series. I believe we're now on the 13th or 14th series of the DRMA, which by law is expected to enforce or to establish the regulatory framework for persons to conduct themselves in protection of themselves and their communities, families, and others. So that act is in effect. And it is in effect, and it speaks to gatherings in any public place not exceeding 10 persons at a time. That's a restriction that is in place. Each person at a gathering in a public place shall maintain a distance of 6 feet from other persons. That is in place. It's a restriction. When in a public place, each person shall wear a mask fitted to that person's face so as to cover the person's nose and mouth. The mask wearing is still in place. It's a restriction under the DRMA. All persons arriving in Jamaica are required, or before I go there, a person who is ill with a respiratory illness or a flu-like illness is directed to remain at home until the person has fully recovered from the illness, unless seeking urgent medical attention, part of the DRMA. And I could go on. There are several components of that. A person who is ill with COVID-19 shall, except for the purpose of seeking urgent medical attention, A, remain in isolation at a home or government facility and remain isolated from other persons in that facility, abode, or place of residence. And I raise that to say, finally, before questions, that, you know, it's not correct to give the impression that somehow we have been, we have taken a hands-off approach in response to the threat by COVID, even during this fourth wave. The reality is we do have restrictions in place. Those are quite clearly outlined. They are being enforced, but it is not so easy to enforce it in every single part of the country when there are other issues around enforcement. Crime is a big issue, limited numbers. We have prepared and continue to prepare our hospitals. I'm hoping in the next week or so the field hospital in Westmoreland will be open. And we continue to make the necessary arrangements to support our medical team to prepare themselves and to deal with the situation as we see it. We are communicating through advertising and other forms such as this one to ensure that the public is kept aware. And the vaccination program continues in earnest with several sites around the country. Now that is our preparation and operationalization of a plan. And it would be incorrect to suggest that somehow we have been insensitive to what is happening. Now, having said that, the argument, the message must be very strong that Jamaicans have a responsibility. We all have a responsibility. Government has their own, you have yours, as an individual, as a company, and that responsibility should be to protect yourselves in the first instance, and certainly if you are not sure, you are guided by the Disaster Risk Management Act, and secondly, to protect your environment, your family members. That is going to be the most effective way, and vaccines being key to that, to overcome this particular threat that we have. And whether it's a fourth wave, God forbid a fifth, or any other, we have to keep reminding ourselves of that. On a closing note, I am encouraged that we can overcome, and we will overcome. There are some features of this virus, you know, it's a milder strain, but it's not to be taken for granted because of the sheer numbers. As you can see, the hospitalization is going up. There are positive features. Our healthcare workers continue to work hard. We continue to provide information. And, you know, despite those challenges, our children are back in school, which I think is a positive thing. And persons have been required to go back to work, which is a positive thing, despite the challenges. And what it shows is that we have learned, there's a playbook, we have learned over the last 2 years, and therefore can provide some level of guidance. But it's guidance that has to and requires a response from all of us. So I encourage us to continue to observe what is articulated around the rules of engagement, and let us work together to overcome this virus. I do believe that we are moving towards the beginning of the end, hopefully. If there's no significant variant strain, then I believe we will eventually over this year come to terms with COVID. Let's keep our fingers crossed, let's hope, but also let's work to ensure that we preserve life and livelihoods and activities as we know it. Thank you very much, and Stephen, your time.
Thank you very much, Minister. Just reminding our media colleagues to use the raised hand feature on Zoom to pose their questions. We have two questions here from Debbie Ann Wright from RJR. She's asking, does the health ministry count already hospitalized persons who later test positive for COVID among those hospitalized for COVID? Some persons believe this is inflating the hospitalization and causing the surge to appear much worse. The second question is, while the health systems are grappling with the current wave, many areas of Jamaican life appear to be operating in a pre-COVID state, with parties every night and crowded restaurants as examples. Is the health ministry satisfied with the efforts of the other arms of government in enforcing the DRMA?
If the persons are ill, they're hospitalized, and they're hospitalized for various reasons. Now, certainly there are going to be persons that are sick. They have various illnesses, but when tested, they are COVID positive. Now, to be able to differentiate how much COVID has contributed to their illness and how much COVID will contribute to their outcome, that is going to be difficult to determine. And so I would hardly consider it to be conflating the numbers, because the persons who are ill, who are found to be COVID positive, have to be treated just as how we treat the COVID persons, in terms that they would be on the COVID wards isolated. And also, as we said, many of them may develop increased severity of their illnesses because of the fact that they have COVID as well. So it is not a matter of conflating the numbers, because you would recognize that we publish the persons that are moderately, severely, and critically ill, and these are persons that are ill with COVID. That those are the numbers that come out in our daily updates. The numbers that we present today in terms of bed occupancy would be persons that are suspected and confirmed to have COVID.
Well, the challenges around enforcement are real, and they are real because there is a lot of laws to enforce. The deviant behavior in the society, whether it is criminal, civil, or otherwise, does require significant resources. And when you experience the level of positivity that you have, the response to that oftentimes, in terms of enforcement, becomes very difficult, having to manage all the other things that are there. And so while I do believe that many agencies try their best, I think we are at a fairly high pressure point where a lot is going to depend on the willingness of our people to voluntarily comply with the rules, recognizing that self-preservation is at stake, and they really ought to be taking action in their own interests. We have seen a number of cases where agencies of the state, the constabulary and others, have apprehended, have charged persons for breaches, but the sheer number of persons involved in the not observing these rules, I believe, creates a dilemma because of just the limited capacity to enforce. So the answer to your question is, I believe there's an effort that is made, and more often than not, a genuine effort. But I do believe that sometimes it's overwhelming because of the extent to which persons just do not want to comply. And this is an important point, I should add, because this is a challenge with even adding on additional laws around compliance. You have to also be able to enforce, and there's an issue there as it relates to the capacity. and the extent to which that enforcement is required. It's not an excuse, but it is a reality that we have to confront. Sure.
Yeah, I just want to clarify something further in terms of the question that I responded to earlier. I recognize, that there was something posted in social media about Jamaica should start looking at publishing only those persons that are affected by COVID that are hospitalized. I just want to say that we have, right from the start, we have always published two sets of data in terms of COVID hospitalizations. We have always published the moderately, severely, and critically ill persons in terms of those that are affected by COVID. And when we look at the trends, we can clearly see the trends in terms of those numbers going up. We have also published those that are on mechanical ventilation and high-flow nasal oxygen due to COVID, and we can see clearly that those numbers are going up. We have also published continuously the number of persons hospitalized that are confirmed and suspected with COVID, and that gives us an idea on the pressure in terms of bed occupancy. So the two sets of data shows two different things, but it shows, one, the pressure, increase in pressure on bed occupancy in terms of those hospitalized, confirmed, and suspected. And some of those will include persons who would have come into hospitals for other things and then would have been confirmed with COVID. But we've also always published the other set of data in terms of the moderately, severely, and critically ill with COVID. And we can clearly see that those numbers are going up, and with each of the surges, we would have seen the rise in those different categories being published.
Thank you very much, Seymour. Thank you, Minister. Shamila pulling from TVJ is asking, why is there another delay in the field hospital in Savlamar? And she's also asking, have we confirmed that Omicron is in Jamaica, or will the genome sequencing machine doing samples now confirm that?
I'll speak to the field hospital and allow the CMO to speak to the particular variant strain. I don't know if it's a delay. I've been there twice, and the finishing touches are being added to the Savlamar Hospital. It's a nice facility. In fact, it's a little different from the others, and maybe that explains the length of time it has taken. It was built, the decision was taken to build a base, which includes bathrooms and some other facilities around that base, and columns along the base, and then place the temporary structure, the tent, if you will, on top of that base in an attempt to, over time, convert the base into a ward. So essentially accommodate an expansion of the Sav hospital because of the need for that expansion. So what would have taken a much shorter time if it were built the way the others were, which was just to create a temporary base and lay the tents. In this instance, the foundation was deliberately designed to accommodate a concrete structure, which we plan to, once COVID passes and we no longer need, or it deteriorates, the tent, we would then put a substantial addition on that will then convert to a ward.
we will be getting more recent results. The results that we have been getting have been dated up to the 8th of September. Those results would not have indicated the presence of Omicron in those samples. We still have samples out with different of our partners overseas that for later samples in December that we have not gotten back results as yet. But now that the genomic sequencing is coming on stream at the University Hospital, we do expect that we can update the public more regularly in terms of the presence of any variants in country.
Thank you very much, CMO. We're going to go to Jidana Murphy from the Gleaner.
Good evening. 3 quick questions here for the CMO. How many pregnant women are hospitalized with COVID-19? What is the vaccination status of COVID-positive pregnant women? And how equipped are hospitals to provide maternal and fetal monitoring of pregnant women on COVID-19 wards?
Well, we did show the graphs. I really would have to go back to the graphs to look at the numbers there. So I don't have the absolute numbers. Can you run the cursor on for the pregnant woman? Next slide. No, come down some more. Down some more. 1. Yes. Can you run the cursor on it so we can see? That looks like 20 on the, what date is that? What date is that, Stephen? The 17th? So, yeah. So that looks like on the graph that you're looking at on the screen, that looks like about 20 on the 17th of January. So that would be pretty recent numbers. In terms of being equipped to manage the patients, in terms of monitoring, certainly we would have put in place the ability to monitor the patients. We have different areas that have been set up. In particular, at the Victoria Jubilee Hospital, they would have created the different areas for the management of those antenatal patients as well as the patients post-delivery. Of course, the spaces are not endless, and if it is that we continue to have increased numbers, then we may be challenged in terms of finding the high dependency spaces. In other hospitals as well, especially the regional hospitals, we would have increased the capacity over the last 2 years, and especially in terms of with the addition of the work done through the PROMAC program, where we would have put in maternity high dependency units. So we do have the capacity, but one of the things that we are challenged by when it's not space, it's staff. And that is a very serious problem that we have. Some of our hospitals have indicated that the shortage of critical care nurses will affect our ability to manage, because even though we're not overwhelmed by the demand for high dependency spaces, but we will come under pressure in terms of having the staff to manage those spaces. We are seeing that increase again in the number of our nurses that are migrating, and especially our postgraduate trained nurses, like the critical care nurses. There's a high demand overseas, so we do see that there has been considerable loss of those critical care trained nurses, and that will hamper our ability. So the challenge right now is not so much space or equipment, but staff. But I mean, we could reach to a point where we are challenged for space if our numbers continue to rise.
Thank you very much, Simo. I'm going to go to Emma Lewis.
Hello, sorry, good evening. Yes, Minister Tufton mentioned that this might be the beginning of the end, and I just wanted to get a sense of, I'd already written down this question to ask, but when do you think we're likely to reach the peak of this current wave? And will the fact that there are so many unvaccinated people slow down our recovery from that peak? I mean, is it likely to sort of drag on longer because of that? I just wanted to get an idea of the sort of time frame we're looking at. People keep saying, oh, it will soon be over and then we'll be back to normal once Omicron is over. But also the CMO just mentioned that Delta is still with us. So I want to get just a general idea. Thank you.
Emma, it's difficult to answer that question because if we look at a range of countries and we look at their epi curves, what we realize is that several countries, most countries are still climbing in terms of what's happening in this latest surge. And so it's difficult to predict, and some have been doing that from even before we started to climb on the 20th of December. So the pattern, you know, to say that this is what is going to happen, it's not clear. And we would have seen one country in South Africa where we saw that they peaked and there was a rapid decline. I can't say if that is going to happen because I don't have very many countries to look at to say what has been, you know, what has happened there to say that this could be the Omicron pattern or what. But, you know, when we peak, it does not necessarily mean we're going to take a short time to drop. A lot of people seem to think that we can plateau for a while, especially because of the things that you say in terms of the number of unvaccinated persons. When we see that we have the densely populated areas like St. Catherine and Kingston and St. Andrew having large numbers, we know that the potential for exposure is great. And so those parishes tend to take a longer time to settle down and kind of stretch out the surge because it just takes longer to get those numbers down. So while we are hopeful that we will have shorter periods of illnesses with Omicron, and that may in fact make the surge not so wide, it's really very difficult to predict just because of the sheer numbers that could be affected and the rapid transmission of the virus, especially, as I said, in those densely populated areas.
Thank you very much, CMO. I'm going to go to Damien Mitchell from the Gleaner.
Thank you, Stephen. I have three questions. I'll ask two now and the other in the go around after my colleagues. My first question is to the CMO. CMO, can you indicate the severity of the backlog in the treatment of people with non-communicable diseases whose clinics have been impacted by the resource demand because of the COVID response?
That's a difficult question, Damien. What we certainly know is that we've put in several measures in order to ensure that there is continuity of care. We have a call-out system in some of our hospitals where they call the patients and make a determination of those that really do need to come in or those that need to just to have their prescriptions repeated, and arrangements would be made for the pickup of prescriptions. We have seen in our primary care system that through the NHF we have been looking at various ways to get prescriptions to persons, including delivery of prescription items in our most vulnerable populations. We have had the lengthening of the prescription period from 3 months to 6 months in order to ensure that persons are do continue care. But there are always going to be those persons that get left behind. And that's a real challenge because we have a lot of persons who their illnesses will get worse. And, you know, just because they're not being seen, they may make an interpretation of what is happening that is not so bad, but it continues to worsen. So there's no doubt that, you know, scaling down the clinics and the reduction in numbers because of maintaining of infection prevention and control measures in the clinics, there's no doubt that it will affect our patients. And that's why, you know, we really need to try to get back to normal, to see these patients as quick as possible. But I think that this period over the last 2 years have forced us into developing innovations that have helped. And certainly a lot of these practices that we have put in place over the last 2 years have made accessibility a lot more for some persons, and we will continue with some of these things. But there's no doubt that we're going to affect it. I can't quantify it at this time.
Thank you. My next question is to the Minister. Dr. Tufton, would there be any benefits from additional COVID containment measures such as no movement days or tighter restrictions in terms of curfews at this time?
Well, it depends on how you define benefits. The truth is that the ultimate response to COVID is to stop all movement, which means that you wouldn't be able to go to work, nor would I. Your children wouldn't be able to go to school, and the virus would have a pause. And then when movement resumes, you eventually get back into a rhythm. So with the virus. So there's no doubt that stopping movement or restricting movement impacts the virus. We have seen that in the ups and downs of the trend of the historical data that we have. The challenge, of course, is the extremity of a response against the impact on other areas of life, including health-related areas. And that's the dilemma of the challenge that we face as policymakers. How do we balance that? So I don't think your response is going to get, it can't be a either or. It has to be how you balance. And I do note that some persons feel that the restrictions should be greater, but what should not be implied is that there are no restrictions. The issue is how you manage that restriction in the interest of trying to achieve that balance. So yes, if you totally stop movement, it would have an impact for a while, but that impact would come with significant consequences. So it's a matter of how you create that balance. Thank you.
Thank you, Minister. We're going to go to Zara Burton from 18 Degrees North.
Thank you, Stephen. Good evening, everybody. My questions are for the CMO, and there are about 4 of them. So if you could take notes, I'd really appreciate it. Okay, so you said last time when we had the COVID conversations that 80% capacity or more for some of the larger hospitals. And again, in a release this week, we were reminded that because of chronic diseases and just other illnesses, general admissions were already up. Can you give a sense of what is happening, why this is happening so much in terms of just overall capacity for general admissions? Also, in terms of general admissions, again, and this is a personal experience that I had in the last couple of weeks up at UWI Hospital, is there a management issue up there? I'm not discounting what they're going through with COVID, but just based on my own personal experience with my mom, where CT scan was ordered, UWI said they didn't have any, what they call it, contrast, right? No dye to do the CT scan. And then they eventually found 2 bottles, like after many, many hours of waiting. The nurse came by, said that the doctor prescribed Panadol. Then she came back, oh, no Panadol. So there seems to be a management issue at University Hospital of the West Indies. So can we get a sense of what's happening from a management perspective over there? Thirdly, You mentioned that capacity, bed capacity, a while ago in your presentation, 100% bed capacity week to week, right? Why are hospitals so overwhelmed and overburdened? If you had told us that you were prepping for this fourth wave, and if in your projections from the previous COVID-19 conversations, you were predicting approximately 2,500 hospitalizations in a peak week, you mentioned today 800 something beds occupied. What if we get to 2,500 hospitalizations? What is the level of preparedness for that? What is the plan? And you mentioned today nurses leaving. Is it time to maybe bond our nurses again? I don't know. I'm just asking, what is the plan to cope with that serious influx that you're forecasting based on your own modeling? And then fourthly, what is the recommendation to doctors in terms of treatment regimen for those who are vaccinated and still get ill with COVID?
Okay, in terms of specific management issues within a hospital, especially with regards to specific situations, I really wouldn't be able to comment. It is, we continue to face these challenges, and the answers are not specific because they cover various areas, maintenance and management of inventory. All of these things are part of the management of the hospital, and I'm sure there are supply issues and various issues that may contribute. So I wouldn't be able to speak specifically on this, but generally I can say that we are plagued by these repeated complaints, and it is something that we are trying to address in terms of the management issues generally throughout our facilities. So this is something that certainly the regional health authorities are the responsible agents for the service delivery sites. The university hospital has its own board, and I think that they are making efforts to improve in these different areas. In terms of the plans, so certainly we would have from our modeling indicated that we would have gone over the 1,200 persons that we had in beds. So we would have put aside 700 or so beds, a little over 700 beds that were designated for COVID. And it certainly means that once we go over that, we have a bed capacity in country of approximately 5,000 beds. And this is why we would have to go on emergencies only after we reach a certain point, because once those 700 beds are full, it means that we have to cut down on the non-emergency type of cases that come into hospital to make space. So certainly the plan would be that, you fill the beds designated first, but once you see that the numbers are going up, then we would have to cut the admissions from the general stream in order to make allowances for beds. And that is because we really don't have an unending capacity. Our capacity is, we have over the last 2 years increased our capacity by putting in additional areas, field hospital, at a semi-permanent structure at St. Joseph's Hospital and at Falmouth Hospital, and temporary structures at the Spanish Town Hospital. We would have put this also in at Maypen Hospital and now put it in at Savlamar Hospital. We would have recruited spaces that were not necessarily bed areas within hospitals, and converted those into areas for additional beds. We would have built some additional areas at places like Cornwall Regional Hospital. So we would have increased the capacity in terms of the absolute number of beds. But again, it's not an unending supply. And so once you reach to that point, you have to cut down the intake from the other avenue that the patients come in by. And that's what we have done in terms of the emergencies only. And we would have indicated that to the public in our planning, that once we reached a certain point, it's not that we can't keep adding beds, because there are other issues that come out that would contribute to making a bed space, and one of that is staff. So no matter how many beds you put in, you still have to find the staff, and we know that we have challenges where that is concerned. So that would have been our plan that we have outlined here at this press conference, that once we reach to passing that 700, we would go to emergencies only to cut down on the intake from the other sources. In terms of the management of COVID in the vaccinated individual, the management is the same for COVID. So persons that are admitted for COVID would be managed accordingly, according to our treatment protocol. Clinical protocols are circulated and are being used in all our hospitals, and our patients would be managed in the same way as the other patients, because the management is based on the symptoms that they present with.
All right, thank you very much, CMO. We're going to go to Roxroy McLean from the Gleaner.
Good evening. My questions are to the Minister and the CMO. Minister Tufton, in regards to the reopening of the entertainment sector, what the numbers in terms of vaccination and infection should be reflecting for you to say it is safe to lend your support to the reopening of the sector? Two, the British government has recently lifted the ban on its mandate for mask wearing in public spaces. How likely are we to abandon the need to wear masks in public? And my two questions to the CMO are, the multisystem inflammatory syndrome is said to be a serious condition that appears to be linked to the novel coronavirus. Are we seeing this amongst our children? And how close are we to the peak of the fourth wave of this virus?
All right. So yes, we have been seeing cases of multi-inflammatory syndrome in children. I don't have the exact numbers. I didn't come prepared with that data, but we have been seeing some cases in our hospitals. And right now, and this is another reason why persons should not believe that we should just allow Omicron to fly through, because there is the post-COVID complications, long COVID syndromes that span a wide range of specialties and can affect any age group. And right now, we are planning that we probably will see more of this syndrome coming out of this surge, and so we're making sure that we have the necessary testing capacity in country to be able to manage, to diagnose these cases. In terms of the, what was the other question, Stephen? Oh, how close are we to the peak? About 2 weeks ago, we said it would take us about 3 to 4 weeks to get to the peak. I think that we could be looking at another 2 weeks before we get to the peak. But, these are estimations, and certainly it depends on the level of responsibility within the public, because in terms of adhering to the infection prevention and control measures, persons need to adhere to these, because it really is in your hands how long part of it is in your hands, in the hands of the population, how long it is that this this surge goes on, and how long does it take for the numbers to go down. It just means that you have to ensure that you follow the rules in terms of the infection prevention and control measures, because that is what is going to stop the exposure and stop the spread.
Okay, so the two questions for me would be the mask wearing and the entertainment industry. All right, so on the entertainment industry, again, I think you have to, it's not a black and white issue. You have to look at the gradual relaxation in degrees. The fact is, there is some entertainment that occurs now. I think you can go to the cinema, if I'm not mistaken, and watch a movie. And, you know, so it's not that. So if you're referring to entertainment as in large parties and large stage shows and so on, then clearly where we are now with this positivity rate, you're not likely to see that during this period. Now, we hope that this is going to be sufficiently short-lived, and we will see adjustments over time, not solely my decision, obviously. It's a function of the environment, the advice, and ultimately the cabinet. What I would say, however, is that Jamaicans need to appreciate the relationship between securing themselves, including vaccination, and restoration of normality in a country, which includes entertainment. We can't have our cake and eat it. So if the population is or continues to be vulnerable by virtue of the lack of protection, non-vaccination, and we continue to have waves as we have had up to this fourth wave, then it makes it more difficult, particularly because we have to prioritize how people congregate and therefore manage the risk. Essentially, what we have done, the government, is to prioritize the gatherings around schools and getting our children back into the classroom, recognizing that there are some risks there, but weighing in the balance that the greater risk is to keep them out, having been out for 2 years. So even with the case of people coming together, because of what is happening, because of the strain, because of the high positivity rate, the hospitalization, the threat to healthcare and so on, or health services or health response, we have to decide how we allow activities that allow for that kind of risk profile around people coming together. And essentially, effectively, what we have done, what the government has done is said, okay, tell you what, if we have to congregate, let it be our children. Let us offer them an opportunity to develop and to get back into a classroom setting that they can learn and become meaningful adults. Now, that is not to say that the entertainment industry is not very important, and that is a very important earning, and people depend on it. We fully appreciate that. Hopefully, once the positivity rate goes down, vaccination levels go up, then you can see a gradual opening up of that. And that is how I would see it happening, except, of course, that it's subject to the advice and to the decision of cabinet. On the mask issue, you know, one of the unfortunate features of the COVID response in Jamaica is the extent to which persons adopt or attempt to adopt what happens in other jurisdictions as standard recommendation for why we are deficient and why we are not doing what we should be doing. And I'm not suggesting that you are doing that, but I've seen the tweets, I've heard the calls, I've gotten the WhatsApps, the emails, and so on. Because a country takes a decision that they think is in the best interest of their population, there's almost an automatic assumption by some, and sometimes persons in very high places, very accomplished, that because the UK is doing it or the US is doing it, we must do it too because it is the right thing to do. I think that's a very naive position, frankly speaking, and it ignores context. And in every decision you take around matters of this kind or other matters, whether you're running a business or you're running government, context matters because it is the unique features of a circumstance that determines how you respond. So take the mask wearing as you have mentioned. The fact is that the UK has a very high much higher vaccination rate than we do, including booster shots. They have far better hospital facilities than we do, including personnel, and they have other things working in their favor in terms of how the virus has passed through their population, where they have gotten a more improved chance of dealing with any particular outbreak, either across the country or among any segments of the population. In our case, we have a 22% vaccination rate. We have an hospital that has a capacity of 1,200 beds before we start running into significant difficulties, and other forms of inputs like oxygen that if we are not careful and it becomes a free-for-all, then we end up with persons dying because they're unvaccinated, as the data suggested earlier. So it is a naive position to say, as some have, that because the UK is lifting mask wearing, we should lift it too. To remove masks at this point in time would be tantamount to a free-for-all. Because frankly speaking, I think the masks are what is helping a lot of us not to get infected. And a free-for-all will almost make it a Wild West with a vaccination level of 22%. And I would strongly urge us, when we place our voice around these issues, we take a little time to understand the context and the circumstances and the difference between ourselves and others. And at this point in time, I believe we're doing the best that we can. And indeed, we're even erring if one were to be liberal in their views on the side of more opening rather than less. And we are seeing you can see the manifestations of that, a 50% positivity rate. To do more, as others have, like removing masks, would, I believe, create significant challenges for us. And I would further say the very same people who are telling us to do more are the ones who are going to tell us that somehow we have not prepared sufficiently to deal with the consequences. And so the government gets the backlash. So we have to be careful that we are focused and that we understand why we need to do what we need to do in the protection of our population. And it's the people that will always have to come first in terms of serving the greater good in this instance. Thank you.
Thank you, Minister. I'm going to go to Stevie Simmons from Nationwide.
Hi, good night. I only have one question. Have you recorded any deaths in children from the virus who were partially or fully vaccinated?
In terms of I can speak more confidently on the fully vaccinated, but I don't think that we have any children in the partially vaccinated group either. But I know that I have looked at the deaths for the fully vaccinated, and there are no children. And you also asked if there was anyone who did not have comorbidities. And no, they all had comorbidities. There was one person who was vaccinated overseas that we saw that there was a death, and we didn't have information on the person in terms of the history. So I can't comment on that person, but all the other persons had comorbidities. No children.
Thanks, CMO. We're going to go to Damon for his follow-up, and then we can close.
Thank you, Stephen. My question may be to the minister or the CMO. I'm not sure who may want to take it. Can you explain the apparent halting of the contact tracing among individuals exposed to COVID-positive persons? And has the ministry developed an early treatment plan that could eventually lead to fewer COVID hospitalizations?
I didn't know the contact tracing aspect.
I wouldn't say that we have halted contact tracing. Contact tracing certainly has gotten a lot more difficult over the last couple of weeks. The number of cases that we have and several challenges, division of resources that we have. But and there has been, and I think I've spoken about this at the press conference before, that we have less cooperation from persons who are contacts because they don't want to disclose because of the possibility of being restricted, any kind of measures being imposed. So, but I wouldn't say that we have finished, we have halted. What I can say though is that generally speaking, at this phase we are in the pandemic and having gone through all of these surges, contact tracing as a means of containment. Remember now that when we started out with the management of COVID, it was about containment and trying to hold it to prevent it from getting out of the bag. But now it's out of the bag. And so containment measures are less compared to prevention, which is vaccinating. Now that we have the option of vaccination and the wearing of and the using of your infection prevention and control measures, it really has to focus a lot on prevention of exposure, because it's difficult to contain because there are just so many cases.
Thank you very much, CMO. The final question is, there's seeking clarification, asking why general admissions in hospitals are so high, if any thoughts as to why so many persons are getting sick at this time.
This is generally speaking, year to year, when you look at the pattern of admissions, you will find that starting probably late October, going November, December, January, going to about March, that's when we tend to have our highest numbers in hospital. And a lot of it comes because of the coming on to the holiday season in December, when we tend to have more, believe it or not, we tend to have more interpersonal violence. We tend to have more crashes on the road. So there, from trauma, there is an increased numbers. And then also from the complications of non-communicable diseases, we tend to have more persons tend to not be so compliant with their medications during the holiday period, and that kind of stretches across into the new year. We also tend to have more detection of illnesses because we have a lot of relatives coming from overseas, and a lot of people who may have been neglected in some way, attention is now placed on them, and they tend to come into our hospitals, and they may not it doesn't take a short time for them to return home. Also, we tend to have a change in temperature coming to the end of the year, going into January, February. So you tend to have more illnesses that are associated with that in terms of respiratory illnesses, that we would see more asthma cases, more flu-like illnesses and other, even though right now we have not necessarily detected influenza type A or B in the samples that we're seeing. There are other respiratory viruses that are out there, and they tend to be, this is a time of the year that we tend to see a lot of that. So we're still in the flu season, the respiratory season, and the other illnesses contribute. So this is the time of the year that we see this, and this tends to go until about March.
There's one more follow-up, Simon. They're asking if there's a treatment plan to help to reduce the hospitalization. Do we have an early treatment plan that could help to reduce hospitalization?
Well, the early treatment starts, of course, first of all, with prevention. In terms of getting vaccinated, that is the one way that you're going to prevent severe illness and hospitalization. Certainly, the statistics that we have here have shown that we do have high protection from that in our population. But in terms of the management at home, when doctors see patients who are having respiratory illnesses, viral illnesses, flu-like illnesses, there are always quite a bit of advice that is given to persons in terms of enabling them to recover early, in terms of ensuring that they have adequate rest, they maintain hydration, they ensure that they are eating even though the appetite is decreased. Many persons will take some supplementation, vitamin C tablets, other kind of supplement to boost their immune system. And some persons just will eat, the eating healthier will also help to boost your immune system. So these are pieces of advice that all doctors give to their patients. And, I'm rather surprised, coming out of this that it is like this type of advice is new and restricted to COVID, because these are things that we have always advocated for in terms of speedy recovery for persons who come down with viral illnesses.
Thank you very much, CMO, and thank you to our media colleagues for those questions. We'll now close with the remarks from Minister.
Thank you very much. So not much to say. It's now 9 minutes to 8 by my watch. And so I think we've been at it for a while. I want to thank all who have participated. Thank you for your questions. Thank you for listening. And thank you for the coverage that you will give to educating, informing the public on this very important national issue. Thanks to the CMO and Dr. Ennis, who is on standby, Steve and his team, and the technical team who are here at our Emergency Response Center in New Kingston. It's a challenge that continues. We monitor and respond on a day-by-day basis. We will see what this coming week brings. We have to pivot as necessary. I want to thank those who are involved out in the field. While I think we are dangerously close to, the bed count, and while I think that, the positivity rate and reproductive rate signals continue to increase, I also want to pay tribute to those who have been managing this process. There is a playbook for COVID-19. This is no longer a novel virus. We have been at it for the last 2 years. We have gone through ups and downs, and so I do believe that we're better able, with the experience to date, to manage the process, as tired and as fatigued as we all are. So we will continue to drive ahead, and we ask you to continue to observe the protocols, to get vaccinated if you're not, get your booster if you haven't yet gotten it, and we continue to provide the information as necessary as we seek to go through the challenge and restore the normality that we all seek. Thank you very much. Have a good evening.
We're at the University Hospital of the West Indies Microbiology Lab, where we now have working the sequencing machine that will test for the Omicron variant strain of COVID-19. I know it's been a long time coming. We had the machine for some time. We had to wait on the trainers to come and train our locals. Our local people are excellent.
Hi, I am Dr. Walker from the Department of Microbiology. We are in the process of sequencing our first samples from the Ministry of Health, and they're being done on this machine here, which is the MySeq next generation sequencing machine. This is the first run that is occurring currently. So the machine basically is going to be analyzing all the samples that we have all at once. What it's going to be doing is actually slowly building each DNA strand for each sample, and as it does this, it's able to see what exactly is the composition of that DNA or nucleic acid that it's looking at. Over time, it's going to have a profile generated of what that